Welcome to this episode of Psoriasis Uncovered, a podcast series produced by the National Psoriasis Foundation, the nation's leading organization for individuals living with psoriasis and psoriatic arthritis. Join us to hear our guest speakers uncover topics that lead to a better understanding of the disease and management, to coping and thriving with psoriasis and psoriatic arthritis.
Welcome to a special podcast brought to you by the National Psoriasis Foundation. I'm Dr. Jeff Stark, a board-certified rheumatologist and head of medical immunology at UCB. Today, we are here to talk about a new clinical frontier in the management of psoriasis, on-treatment remission. Joining me to navigate this discussion is a leading dermatologist and researcher in psoriasis management, Dr. April Armstrong.
Thank you for having me, Jeff.
Thanks for being with us. I'm also excited to introduce another guest, an incredible patient advocate who is here to share her perspective of living with psoriasis. Elizabeth Park, thank you for being here and joining us today.
I'm so excited to be here, Dr. Stark.
Thanks. Dr. Armstrong, can you start us off? As you think back on the last maybe 15 years, how does the atmosphere around psoriasis management in a dermatology clinic in 2026 feel different than way back then?
Well, I would say it feels very different, almost night and day. I think when we're thinking about where we were 15 years ago, we are beginning to see this evolution and revolution in terms of systemic therapy. But I would say most of the time we would feel challenged in terms of facing a patient who may have very severe psoriasis and really thinking about where we can go with that patient. Can we get that patient to clear, almost clear? But I would say these days in the clinic, it's really a joy. It's really satisfying, I think, for a lot of our dermatologists and dermatology providers to be able to see our patients with psoriasis because we know that we have therapies that really can change their lives. Few things to note. One is that what drove this evolution is a deeper understanding in the pathophysiology of psoriasis. And this is really important because this newer understanding and the development in the area of translational science have really led to the approval of a number of different classes of medications, both in systemic medications as well as topical medications, for example. So the therapeutic options for our patients have really increased. And also another major change is our treatment goals. What we saw traditionally, for example, 15 years ago, we were looking at PASI 75 or at least 75% improvement from baseline after about 4 months as a reasonable goal to aim. And I would say these days, when we're looking at treatment goals, we are really going towards and really are at treatment goals such as complete clearance or near complete clearance, such as PASI 90 or SPGA 0 or 1. So with our therapies available, we see that many of our patients are benefiting from this, and also our overall expectation of where we can go with our management for our patients for psoriasis and the overall treatment goals have also become elevated as a result.
I love that story, and especially that sense of the science and our understanding of disease informing the tools that we have and those translating into greater expectations for the patients who suffer with psoriasis today. It's really fascinating to think about all of that changing over the last 15 years. Thank you for that insight, Dr. Armstrong. Elizabeth, I can only imagine what it must have felt like for you being on the other side of the exam table. Tell us about those early days of diagnosis and management of your psoriasis.
So I was diagnosed when I was, I think, about 11 years old and started with plaques on my scalp. I'm 28 now. Initially, my family had taken me to the dermatologist, and at that time, I was first misdiagnosed with seborrheic dermatitis. So I had received some topicals, some over-the-counter shampoos, things like this, and to no avail. I ended up going to see a second dermatologist for another opinion. And at that point, I was diagnosed with psoriasis. And it was localized to only my scalp. So in that sense, it was somewhat manageable, but the plaques were quite itchy, thick, and ultimately they ended up giving me all sorts of topical steroids, prescription shampoos, over-the-counter shampoos, and even like different types of oils for me to apply to the scalp. And this was such a vivid memory of mine. being 11, 12, 13, something like this. And in middle school, I'm sleeping with a shower cap with oil slathered all over my scalp. And it's uncomfortable, disrupts your sleep. And then I'm there waking up super early in the morning just to spend like an hour trying to get this oil washed out of my hair before school. So, and on top of all of that, with all that work, didn't really treat my plaque psoriasis. So ultimately ended up stopping the oil and just trying to stick with some of the topicals, but it wasn't a great experience. And eventually in high school, I found a clinic that was able to do phototherapy treatments. So I switched over to that and I did several sessions of that. Also not very helpful for me. I remember just one time it cleared a small patch after they accidentally burned me. It was just a crazy experience, to say the least. At that point, then I moved on and I started going to college. When I was in college, it ebbed and flowed. There were times where naturally my plaque psoriasis actually got a bit better, but about midway through school, it got worse and it continued to get much worse. At that time, no one was offering me anything more beyond topical steroids, even though it was affecting about 10% of my body. So it had gone from my scalp into my face, my trunk, back, arms, legs, just pretty much everywhere in dispersed amounts, and definitely really increased the discomfort, being self conscious, and so many things, and fear that it would continue to grow. At that time, I was also experiencing some joint pain. So I had heard about psoriatic arthritis and actually ended up finding a rheumatologist to see. And when I saw the rheumatologist, she said that I didn't have psoriatic arthritis, but that because my plaque psoriasis was actually so bad that she could prescribe me an oral systemic. So that was a huge unlock for me at that time, starting something completely different that wasn't just a topical. I was on that oral systemic for about 3 years. And while it did kind of manage some of my symptoms on my body, it didn't fully clear everything. And if you're familiar with these oral systemics, just a slew of side effects that were just horrible. So was also really tough. It was kind of trading one thing for another in a sense, and eventually switched off of that as well.
You've had quite the journey from a young age with psoriasis, and it sounds like lots of trial and error, lots of false starts before maybe finding something that was a better fit, brought you more benefit. I'm hopeful that you're doing better these days with the course of treatment that you're on now, but tell me a little bit about maybe how things have gotten better and what do appointments with your dermatologist look like now compared to what they looked like back then?
Yeah, for sure. I think the oral systemic kind of journey kicked off the next phase where I was able to go back to my rheumatologist and say, hey, I'm not happy even with this drug here. And I want to know what else is out there that could potentially be better for me, and ultimately ended up getting transferred back to a derm and getting prescribed biologic. And so from that point on, I started taking an injection at home every 12 weeks and really noticed a difference in skin clarity. It cleared everything on my body and localized it back only to my scalp. And everything that is on my scalp is much more manageable than it was previously. It's less itchy, thinner, all of the things. I think just talking to my doctor and advocating for myself in a bit of a way that maybe a lot of people are afraid to do or don't know that they can do, it totally changed the game for me.
Well, kudos to you for speaking up and being an advocate for yourself. I think it sounds like that was the key to change, and I'm glad to hear it's led in a positive direction. I want to talk more about what a lot of individuals living with psoriasis describe as the smoldering fire of psoriasis. Dr. Armstrong, if we're able to reduce skin involvement by, let's say, 90%, why should we still be adamant about addressing that last 10% of residual skin involvement?
That's a great question, Dr. Stark. Because psoriasis is a visible manifestation of systemic inflammation storm, that's why it's very important that we think about how much residual activity is still left. So when we see residual plaques, it's an indicator that the underlying immune system is still overactive. And we can see this residual uncontrolled inflammation manifest itself in different ways. As an example, there are data showing that individuals with moderate to severe plaque psoriasis, for example, with a body surface area involvement of greater than 10%, and these patients may develop clogged arteries and ultimately have higher risk of heart attacks or strokes. If we do not get this inflammation under control, we could leave the heart, for example, at risk. And perhaps as critically, about 1/3 of our patients with psoriasis may go on to develop psoriatic arthritis. But we believe that there may be possibly a window of opportunity where if we intervene early enough in psoriasis management, we may be more likely to prevent progression to psoriatic arthritis and the joint erosions that define it.
So I want to dive a little deeper into what we would consider a treatment success. If a patient feels fine but has a few stubborn spots on their elbows or on their scalp, would you still consider that a failure of treatment?
Dr. Stark, I would say that's a clinical question that comes up all the time. I would probably consider using a different word than failure because when we're thinking about this is really a treatment journey, and I may call it incomplete success, for example. We know from recent imaging studies like PET CT scans that even patients with lower PASI scores or psoriasis area and severity index scores, for example, scores less than 10 or less than 15, these patients can have increased levels of aortic inflammation. So my message to my fellow colleagues who are really seeing a lot of these patients in our clinic is let's not stop at good enough. When we're thinking about the residual plaques, it's a sign that there is underlying cytokine pathways and inflammation that is still active and still dysregulated. Therefore, I think when we're thinking about in this day and age in 2026 and beyond, we are really thinking about aiming for complete clearance for our patients.
Elizabeth, when you hear that even minimal skin involvement could be a sign that the inflammatory storm is still quite active, how does that make you feel?
I think that's really surprising for me because I always thought psoriasis was just on the skin. And I think hearing that, it definitely changes my perspective and definitely makes me want to get to that 100% clarity. Whereas maybe before it was more just about, what's visible.
And I know you hinted at this in telling us a little bit of your journey previously, but have you had any personal experience with comorbidities like the ones Dr. Armstrong described, whether that be things like joint pain or cardiovascular disease or any other symptoms that your clinician believed might be related to your psoriasis?
I think I'm lucky in this time right now where my main focus is kind of just being vigilant about if anything changes in my body and being as preventative as possible. So, my doctor and I have definitely talked about getting good exercise, having a good diet, good sleep, and maintaining low stress levels. And that for me also looks like seeing a therapist from time to time just to manage different stress and to learn how to handle stressful situations in a healthy way. And I think that kind of all goes together to kind of help keep things as best as I can.
Thanks for sharing that, Elizabeth. I want to shift now to the point of on treatment remission. The term remission has been used in other areas like rheumatology for a long time now. In treating rheumatoid arthritis, which is another immune mediated inflammatory disease, we use a treat to target approach to achieve remission. With this approach, we monitor disease activity with our patients every few months, and we make adjustments to their therapy to reach low disease activity and ultimately, as we hope, clinical remission. We make it our goal to take action early before patients have to tell us that their joints hurt. And all of these efforts really allow us to intervene before irreversible damage to the joints occurs by addressing inflammation from the start and striving towards what we call on-treatment remission, where our patients still live with the disease, but without experiencing the symptoms of that disease. So in rheumatoid arthritis, we do have clear criteria for what qualifies as remission. These include factors such as patients having at most one tender or swollen joint, or, for example, a blood marker of inflammation at a level indicative of a low risk of chronic disease activity. And of course, the patient perspective is important. And another criteria for remission is a patient report of no or exceedingly minimal disease activity and impact on their quality of life. Dr. Armstrong, thinking about the concept of on-treatment remission now being introduced into psoriasis management, are you seeing any parallels developing between psoriasis management and the existing guidelines for remission in other diseases like rheumatoid arthritis?
Absolutely. And I would say that, Dr. Stark, we've learned a lot from our rheumatology colleagues, as well as, for example, our oncology colleagues in terms of these definitions. For a long time, we dermatologists and dermatology clinicians have evaluated how patients are doing by using more broad questions, such as, how are you doing, or how do you feel? And then we look at the skin. Now, for some of these severe inflammatory skin diseases, we're adopting those same rigorous criteria as you described earlier for rheumatoid arthritis. In psoriasis, we are looking for example, these days, what's called an Investigator Global Assessment or IGA score of 0, or body surface area or BSA involvement of 0% while on treatment for at least 6 months. Basically, meaning that 100% skin clearance, so 100% clear skin, which could act as our no swollen joints in rheumatoid arthritis, for example. Now, it is important to distinguish the definition of on-treatment remission from, for example, cure. In psoriasis, on-treatment remission means that the disease is undetectable because the medication is effectively suppressing the disease. If we stop the medication, for example, the symptoms may return. But while following your therapy for many of our patients are likely essentially can have this undetectable disease in their daily life, which is really an important goal for them.
That's a really important distinction to make. Thanks for clarifying that, the difference that is between remission and what we think of as cure. And hearing you talk about some of those really stringent measures like a body surface area of 0 takes me back to Elizabeth's story when she was living with a body surface area of 10% and how different 0 is from 10%. Coming back to that topic a little more, Dr. Armstrong, I know that you were involved in the research as well as the development of criteria for the on-treatment remission concept that was published last year in JAMA Dermatology. How are we officially defining on-treatment remission in psoriasis in 2026?
Yes, I gave you a very slight peek earlier. So the consensus is really shifting towards a two-pillar definition. So when we're thinking about defining on-treatment remission, and this is a multi-stage process that we involved our patients and many other stakeholders to develop. So the consensus really has two pillars. Number one is achieving complete skin clearance, and number two is sustaining that clearance. So when we're thinking about this definition of on-treatment remission, what we're having is that clearance in psoriasis having this very strict meaning for our dermatologists. We define it as IGA score of 0, or a BSA score of 0%, and also essentially no disease, whether it's measured by IGA, BSA, and sometimes by PASI. Basically, this means that we don't see any visible redness, any visible thickening or scaling as a result of psoriasis, not just minimal disease. Importantly, this sustained clearance is a newer part. When we're thinking about it, it's not just about achieving complete skin clearance, but also the ability to sustain that clearance for a minimal period of time. And that on-treatment remission isn't just a flash in the pan, for example. To be considered on-treatment remission, to achieve that definition, the patients will need to maintain complete clearance of their skin from psoriasis and able to maintain that complete clearance for at least 6 months.
That seems like such a key part of the definition that, a patient not only improves and achieves good control, but is able to maintain that over a period of time. So it's great to hear that that's incorporated in the new definition. Thinking about that patient experience, what about the patient-reported side? Does the definition include any assessment of how the patient feels?
That's also a very important question, Dr. Stark. So the patient feedback was critical for us in terms of defining the definition of on-treatment remission in psoriasis. And our patients, like Elizabeth, had told us that being free from skin flares and any signs and symptoms of psoriasis are very important to them and should be considered as we come up with a definition of on-treatment remission. And one important aspect is that because complete absence of visible psoriasis plaques is often correlated with our patients experiencing no negative impact in their quality of life due to psoriasis, therefore, having and maintaining complete absence of visible psoriasis plaques is especially meaningful in the definition for our patients.
We're really fortunate to have a voice of that actual experience of someone living with psoriasis here with Elizabeth. Elizabeth, what does it mean to you as a patient living with psoriasis to be part of the conversation in determining when you have achieved remission?
Yeah, I think it's such an important part, and it was definitely the unlock for me when I realized that there were higher therapies available, and I just didn't even realize that it was something that, I could get skin clarity from. So I think that's the first thing, and then being able to talk with my doctors and say, hey, this isn't as clear as I want it to be, or I want to go to the next step. Like, I think just even knowing that empowers me more to speak up and ask for that.
I'd love to follow up on that, Elizabeth, and stay with you for this part of our discussion. You've shared very kindly some of your journey with psoriasis with us, and I want to come back to one of the elements that you shared, which is just kind of the mental load of having disease activity and having active psoriasis. I wonder if you could tell us more about what that's like, particularly before remission is achieved. What does a typical day look like when you're mostly clear but not fully in remission?
Yeah, I've had it in so many different stages from just my scalp to 10% of my body. And I would say when your psoriasis is flaring and just on the day to day, of course, you are self conscious about it, especially when it starts to develop or grow. You have fear that it could grow to more parts of your body or become more itchy or more painful. I think it's such an exciting time when you start treatment and you start seeing those plaques disappear and slowly start to fade away, and definitely gives you more confidence to not think about it and not wonder what other people are thinking about it. And I think actually the biggest impact for me was that psoriasis in my experience was just really itchy, really uncomfortable. So kind of just beyond just the way that it looks, it can be something that detracts from your ability to focus on tasks and things like that. So getting clarity has definitely changed my energy levels, my ability to complete tasks and stay focused on different things. So definitely as a student, when I was receiving this treatment for the first time, like, was a huge change in my day to day.
Thanks for sharing that, Elizabeth. I think no one is more expert on what it's like to live with psoriasis than somebody who lives with it. And I think it can be easy to lose track of the impact of psoriasis on our patients. Advocates like yourself really, I think, are constantly reminding us of the importance of including our patients in conversations around the next steps to improve on the standard of care. So thank you for doing that. Dr. Armstrong, we've been discussing this new standard as on-treatment remission rather than using other terms we might use like tight disease control. Do you have a preference for the term we use moving forward as we start to define this emerging goal and put it into practice in the clinical community?
That's a really terrific question, and I know a lot of us are discussing this actively. I think that both terms can be useful, but they carry slightly different meanings. The term tight disease control can describe both the strategy of monitoring closely and adjusting the treatment, and it can sometimes also mean an outcome. In fact, when we were doing a lot of the background research for this, we looked at this particular issue. And the finding from that was that the term tight disease control is oftentimes defined quite variably in the literature, especially in psoriasis literature, where the findings are a bit sparse and the definition vary. Now, when we are thinking about on treatment remission in our research for this, what we found is that for patients, researchers, and clinicians, many actually prefer on treatment remission because it is more intuitive. It clearly communicates that the goal is not just better or mostly clear, but the absence of visible disease while the patient remains on therapy. It is also a goal that reflects the current state of advanced therapies, something that can be achievable. It's a goal that can be achievable. And also, in my own personal opinion, something that's very important to aspire.
That's really helpful to understand those nuances behind the terminology. And I'm sure the research group was very thoughtful in choosing the terms that they did for those reasons. So thank you for sharing that. On another topic, if we think about remission and a state maybe when a patient isn't experiencing any side effects and is actually seeing the desired effects from their medication, do you think there's any risk, Dr. Armstrong, that the onset of remission might instill a sense of security and a patient might stop their treatment against the advice of their physician?
I'm so glad you brought this up because I feel that this is a scenario that can commonly come up in my clinic. When our patients see that they are, for example, completely clear, it's completely an understandable question when they ask, for example, Dr. Armstrong, can I just stop the treatment? So the way I talk to them about this is that when we're thinking about their disease process and thinking about the ability to be on remission and stay on remission, one of the key things we know is that sometimes when we look at the data and we see that patients, when they are discontinued from therapy, for example, there can be a slow return in their psoriasis. So I do share that information with them, and I do want to talk to them carefully if they're thinking about discontinuing the treatment for reasons other than, for example, side effects or the lack of efficacy. So we do want to be clear in that when remission is achieved, oftentimes maintenance through ongoing therapy is important. And then how do we know this? Because we have real world data that helps to inform us regarding what happens when people are maintained on therapy and what happens when they get off therapy, and how vast majority of the patients, you may see a slow return in the disease. And therefore, for example, I oftentimes tell my patient, we compare this with treating something like high blood pressure. Your blood pressure is normal because you're on therapy. And if you stop taking it, the blood pressure can oftentimes then return to an abnormal state. So when we're thinking about chronic diseases such as plaque psoriasis, oftentimes many patients, ongoing treatment may be necessary.
That's a really great point. Thank you for sharing your thoughts and your perspective on that. I feel like we're only beginning to scratch the surface of this important topic, but unfortunately, we're running out of time. Dr. Armstrong, just in closing, do you have any last thoughts you'd like to share with dermatology providers that are listening and who might still be aiming for only mostly clear?
I would say that we are really living at an exciting time where we have advanced therapies that can get many of our patients to complete clearance. And when we're thinking about that and the ability to deliver our patient that outcome, I would say is something that makes me and many of my colleagues very excited, and certainly that would make patients such as Elizabeth very excited as well. I think that the ability for us to make sure that they can focus on other parts of their lives instead of psoriasis is one of the things that drives me and many others towards really elevating the level of care for our patients. So I would say that to many of my colleagues who have been working really hard in terms of managing our patients with psoriasis and really try to treat patients who may have difficult to treat phenotypes, I understand that sometimes it can be difficult for some of our patients to get to that complete clearance. But I would say that for the majority of our patients at this day and age, we as a field together being able to offer options to them that can deliver this level of clearance, I think is very, very exciting. So I just want to not only commend my colleagues for all the great care that they are providing, but also for them in taking time to listen to patients such as Elizabeth and experts such as Dr. Stark and myself, taking the time on this broadcast to learn about this new definition.
Thanks, Dr. Armstrong. I love your vision of what's possible for patients. That's so inspiring to hear. And Elizabeth, a final word from you, maybe for the person with psoriasis who's sitting at home living with a flare today. What word would you have for them?
Yeah, I think everything that Dr. Armstrong said is such great information to have to empower you to advocate for yourself. And I think from my experience where I was misdiagnosed, wouldn't be treated, or got treatment that was less than ideal and or didn't get me the clarity that I wanted, definitely is empowering for me to look at new options and what's out there and continue to get to that 100% clarity with my doctors.
Well, thank you both for being part of this important discussion. To our listeners, thank you for joining us today. This has been a production of the National Psoriasis Foundation. I'm Dr. Jeff Stark, and thank you for listening.
We hope you enjoyed this episode of Psoriasis Uncovered for people living with psoriasis and psoriatic arthritis. If you or someone you love has ever struggled with psoriatic disease, our hope is that through our podcast you'll gain information that inspires you to lead a healthy life and look to the future. Please share the episode link if the content in today's episode will benefit someone you know. You can find this or all future episodes of Psoriasis Uncovered on Apple Podcast, Spotify, Amazon Music, Ghana, Pandora, iHeartRadio, and the National Psoriasis Foundation webpage. To learn more about this topic or others, please visit psoriasis.org or contact us with your questions or comments by email at podcast@psoriasis.org.